Alright guys, in this video I am going to discuss keratoconus. Now it is a condition of cornea in which there is bilateral progressive thinning and thinning of what? Thinning of stroma. Progressive thinning of stroma at central or paracentral region with the apical protrusion. Yes, just write it with me. Central, I am just writing the key points. Paracentral region with apical protrusion, which ultimately leads to irregular astigmatism. Now, what are the conditions with which keratoconus may be associated? It can be Ehlers-Danlos syndrome, Down syndrome, osteogenesis imperfecta, OI, osteogenesis imperfecta. There are some conditions which are acquired, like vernal keratoconjunctivitis. It is allergic, na? So when there is itching, the patient constantly rubs his or her eyes, which actually lead to corneal stromal thinning. Yes, another important condition is, which may be sporadic or may be hereditary, retinitis pigmentosa. Yes, okay, so these are the conditions which are commonly asked in relation to keratoconus. Now keratoconus can be mild, it may be moderate, and it may be severe. So mild is when the keratometry value is less than 48 diopter. Moderate is when it is 48 to 54 diopter. Severe is when it is more than 54 diopter. Mild, moderate, and severe. Okay, now what are the signs? Yes, symptoms. So it is associated with irregular astigmatism. So the patient will have difficulty in seeing the objects clearly. There will be gradual or slow progressive loss of vision. Yes, okay. So the signs are, can you appreciate these vertical lines? Yes, what are these, boys and girls? These are your Voigt's striae. Voigt's is the name of the scientist, and striations are stretch marks on the Descemet's membrane. So this is seen in Descemet's membrane, and these are stretch marks. Yes. Now don't forget that there is another stria, which is Hab's stria. Hab's stria is seen in congenital glaucoma. But the difference between Voigt's stria and Hab's stria is due to tears in the Descemet's membrane, and H for Hab's, H for horizontal. Voigt's stria, they are due to stretching of the Descemet's membrane. V for Voigt's and V for vertical. Your previous year question, boys and girls. Okay. Now, when the striations, they get ruptured. So because there is stretching of the Descemet's membrane, and eventually when it gets ruptured, so it leads to corneal hydrops. Corneal hydrops is when there is edema of the cornea. That means aqueous enters into the stroma of the cornea. So edema. Yes, okay. Now what is this, boys and girls? Can you appreciate this golden brown line here in the form of a ring? So this is your Fleischer ring. Fleischer ring. Yes, and this Fleischer ring is actually due to iron deposition on the epithelium of cornea. Yes, and it is present at the base of the cone of keratoconus. Don't confuse it with another ring, which is your Kayser-Fleischer ring. Kayser-Fleischer ring. Yes, and this is actually copper deposition in the Descemet's membrane of cornea. So are you able to differentiate? One is Fleischer, iron, corneal epithelium. Another is Kayser-Fleischer, copper, Descemet's membrane. Yes, okay. And what next? Okay, so there is another change which you see, and it is seen on the Placido disc. Placido disc is used for the assessment of corneal surface. So it is a test to assess the corneal surface. Now since there is protrusion of the central paracentral region at the center of the cornea or paracentral region of the cornea, protrusion and due to stromal thinning, yes, so there will be unevenness of the cornea. When you will use a placido disc, it consists of black and white concentric rings, and there is a small viewing area in which you view the image, the reflection of black and white rings on the surface of the cornea. And you would see in a case of keratoconus something like this. But if the patient is having no astigmatism, if the corneal surface is even, so this is what you normally see, the normal cornea. Yes, so you can actually see the irregular rings of the placido disc, which will be seen through the viewing area on the placido disc. Yes, okay. Now what is this? So this is your, what you do, you ask the patient to look downwards. When the patient is going to look downwards, let's just suppose that this is the lower eyelid and this is the cone of the keratoconus. When the patient looks downwards, this cone of keratoconus goes behind the lower lid and pushes the lower lid in such a way that there is a formation of a V-shaped mark on the lower lid due to the cone pushing the center of the lower lid. So this is known as Munson sign. That means V-shaped formation of lower lid. This is also your previous year question on asking the patient to look downwards. And don't worry, I am going to show you one patient and then you will actually see how it looks like. I expect you to tell me that, okay sir, this is the keratoconus. Just give me a second. So this is the patient who had come to me, and I'm just going to show you the Munson test. Okay, I'm taking a short history. This is a patient of vernal keratoconjunctivitis. You know that vernal keratoconjunctivitis is more common in males or females? Males who are teenagers, bilateral condition, type 1 and type 4 hypersensitivity reaction. If that is not in the option, go for type 1. If that is not in the option, go for type 4. There is typical cobblestone papillae, है ना? And on constant rubbing, as I told you in the very beginning, it will lead to corneal stromal thinning, which would cause keratoconus, and you will see this Munson sign, as you can see here. Just see this, man. Now, try to appreciate. All right. Now, can you appreciate that there is difference between the two lower eyelid formations? Check out the right eye, check out the left eye. In the left eye, you can see that it is like a V shape, but right eye till now appears okay. So that actually tells me that left eye has significant keratoconus. So this is Munson sign. Yes, this is the Munson sign. Okay, all right. So guys, these are the some real patient videos which I usually show in the class. So I have got a video bank of nearly 300 plus videos. So this was one of those few important videos that I wanted all of you to see. Yes, for the rest of the videos you can always attend my class or maybe on the app or face to face anyway. So that was your Munson sign. What is this? This is your prominent corneal nerve. Due to thinning of the cornea, you can actually see the corneal nerves. Yes, and this is your oil drop reflex on distant direct ophthalmoscopy. There is a direct ophthalmoscope. You do it from a distance of nearly 50 centimeter or half meter. So there is a oil drop reflex. Yes, don't confuse oil drop reflex with that of oil drop cataract. Oil drop cataract is seen in galactosemia. Yes, this is also your previous year question. I am writing it here because I don't want you guys to confuse. Yes, there is another oil drop which is not actually oil drop. It simulates with oil drop. It is oil globule reflex. Yes, oil globule reflex is seen in lenticonus, anterior lenticonus. So I gave you 3 points: oil drop reflex, oil drop cataract, and oil globule reflex. Okay, now Quickly, Munson sign we have done, Fleischer ring we have done, topographic changes. Of course, there is thinning of the cornea, the central part. You can see that it is showing the red color. Red color means there is excessive thinning. Walk's-Eye I have told you, hydrops I have told you. Now, what is Caesar's reflex? Caesar reflex is seen in retinoscopy. So you take the retinoscope, so you move the retinoscopic light from one side to another side, right? You remember, you do it from x-axis, you do it at y-axis. So what happens is, the moment the retinoscopic light, so there is a reflection, there is a red reflex which is projected back. Now this Caesar reflex is actually due to irregular astigmatism. Because there is irregular astigmatism, the reflection of the light reflex will be very irregular, yes, and it looks like it is moving like arms of the Caesar. So that is due to irregular astigmatism. Rizzuti sign is, you take the torch light, you shine it from the temporal side. So if there is cone of the keratoconus, cone in the cornea, the shadow of the cone in the cornea will fall onto the nasal limbus in such a way that it will give an appearance of an arrow. Are you able to appreciate? So arrow shaped shadow. So it is arrow shaped shadow. Yes, all right. So these are the important features. Now coming over to the management, as I told you that in keratoconus there is irregular astigmatism, so you are going to do refraction, you are going to give glasses. The patient may require spherical glass, the patient may require even cylindrical glass. Cylindrical glass are used for astigmatism, so you will give. So if it is of the mild stage, sometimes it is corrected by the glasses, yes, but you have to keep the patient on follow up, है ना, because it is a progressive condition, yes. And second is, you can even go for rigid gas permeable contact lenses. So if you place the contact lens, because you know contact lens cuts off the oxygen supply from the surroundings to the cornea, है ना. So nowadays rigid gas permeable contact lenses are available. The rigidity of the contact lens is going to push the cone of the cornea backwards, yes. So the material which is used is CAB. It is cellulose acetyl butyrate. So this is a typical material which is used. Third is, you can go on for C3R. It is corneal collagen cross-linking with riboflavin. Now riboflavin is your photosensitizer. So what you do is, you remove the epithelium of the cornea, so the stromal bed is exposed. You put in the drops of the riboflavin, so that actually gets over the stroma and makes the stroma photosensitive. Then you expose the stroma, with UV light, yes, so that there is formation of new cross linkages in between the collagen. So corneal collagen cross linking, yes. Okay, so that is your procedure. So you can see that it is being exposed. Now what is intax? Intax is intrastromal corneal segments. Now these segments are made up of a special material which is PMMA, which is polymethyl methacrylate. Yes, this is the same material which is used in non-foldable intraocular lenses. ठीक है जी. So you give two cuts like this and you insert PMMA type. The semicircular segments at the periphery such that it stretches the cornea from the periphery and the cone of the cornea goes inside. So that is your intax. And ultimately you can go on for keratoplasty. So keratoplasty is your optical keratoplasty. There are different forms of keratoplasty: optical, therapeutic, tectonic, cosmetic, yes. And optical is when you do keratoplasty for the improvement of vision. You can also go on for DALK. DALK is deep anterior lamellar keratoplasty, or you can go on for penetrating keratoplasty. Penetrating keratoplasty is full thickness keratoplasty, while dark is your not full thickness, it is partial thickness. It is sorry, partial thickness keratoplasty. So you know that in partial thickness keratoplasty we have got lamellar, which can be deep anterior lamellar, which will include till deep stroma. There can be DSAC, in which you take Descemet's membrane, endothelium and part of the stroma. Then there is DMAC, in which you take just the Descemet's membrane and endothelium. But here, if you have to do partial thickness, which is lamellar, you go on for deep anterior lamellar keratoplasty. Otherwise, penetrating keratoplasty is a good option. So most commonly done procedure is usually penetrating because of its ease. Otherwise, DALK is better than penetrating keratoplasty. But in DALK, first you will have to remove the part of the host, then you will have to remove the part of the graft, then you will have to put it. So it is like, you know, doing a lot of effort and you need a lot of expertise. But penetrating, you simply cut the entire cornea, the full thickness, and you replace it with the full thickness of the cornea. Okay, but please understand that if the patient is having keratoconus, that means there is thinning of cornea, LASIK surgery is contraindicated. Now don't say that, sir, we are doing so much for vision, we are giving rigid gas permeable contact lenses, refraction. Can the patient undergo LASIK surgery? No, because the concept of LASIK surgery says that you remove the corneal flap, which consists of the epithelium till the stroma, a little bit of stroma, such that the thickness of the flap is 160 micron, and you ablate the stromal bed and you replace the flap. But when the cornea is already thinned, so it is usually contraindicated. You don't do LASIK surgery in keratoconus. In fact, whenever the patient comes to us for LASIK, we always evaluate the patient for keratoconus. Yes, so boys and girls, so this is all about your keratoconus. I have tried to cover all the important PYQs, and yet I have been very conceptual. Let me know in comments how you like the video. I'll be coming up with more such videos, and best wishes from my side. Thank you very much.